Okay, so still staying in the topic of neurology, we welcome back by popular demand Dr. Tim Benke from Colorado Children's, and he's going to speak to us about a topic we all care very much about, which Ellie and Kopika talked about, is sleep. So, Dr. Tim Benke, please join us and let us know, how can our children sleep? They sleep, we sleep. You have the answer, right?
Gosh, I wish I did. So sorry. If you're hoping for the secret sauce, it may not be what you're looking for. But I will talk about some things to think about. So with the slides today, I think I made a bad mistake, and I put all of my slides that I could possibly put in, which is because I thought, oh, they need to know this. But we'll get through that. These are my disclosures. The bottom line here, down at the bottom is oh, it got cut off, but basically it said no commercials, and a lot of this is my own opinion. So we're going to talk about epilepsy and FOXG1 syndrome, and then I'm going to talk about present epilepsy clinical data from the NIH-sponsored natural history study, and a little bit that's just, I'll go through it quickly because it's from Ellie's studies, so we won't go over that very much. And then sleep and FOXG1 syndrome, brief literature review, and then I want to talk about something that was related to what Guy was talking about earlier, is outcome measures in a similar developmental and epileptic encephalopathy. Then we'll have questions. So this is the early days of FOXG1. So basically these are two papers. You can't see it, but I'm going to point it out. This one's from 2012. That one's from 2014. And basically these were really small studies, and it was talking about the mean age of epilepsy diagnosis, which was several months of age in one study, and then the number of anti-epileptic drugs was quite a few in this one over here versus there. So we've come a long way since then, and so basically through the NIH-sponsored natural history study of Rett and Rett-related disorders. And the reason how this happened is when the next renewal for that grant went in, we said, well, let's not just do Rett, let's do the other, take care of the other people that are in our clinics, which is CDKL5 and FOXG1. And so we added to studying Rett also FOXG1. And basically, in that study, this was the proportion of people with seizures, and this is the age in months. And so FOXG1 is in green. And basically, what this study showed is that with time, people developed epilepsy. Now, and I want to explain to you what this study means in terms of numbers and how the study was conducted. Because this is not like taking everybody together the way things were done in the data aggregation study. In order to participate in this, we had 62 families with FOXG1, and you had to sign up for regular research visits, which were 2 to 3 hours, where we poured over all of the last details of what happened when your child was 2 months of age, which was really slow and tedious. And so it limited, I think, the number of people that we were able to see, because not many people have 3 hours to come and hang out with me in the clinic while we go through all of these different questions. But basically, what this showed is that in this study, 60% had ongoing seizures. Now, again, so it's 62 patients. If you can see it, it's a bit small up here. And what was found is that the age of seizure onset is a little bit younger than what was seen in the other studies. It's about a year of age, which is what this is down here. And then another piece of information was, so this is, let's read the bottom down here. It says, first seizure, when did the seizures go away? When did they go away, and who had ongoing seizures? So this said that basically 41% had ongoing seizures, but 21% of people, they were resolved. Then the other piece of information way down here is, well, what age did people resolve? And so it was kind of all over the place with this range down here, which you can't see it. I apologize, it's too small. But the average age of when seizures went away was 3 years of age and 36 years of age. So you're going to say, well, how does that have anything to do with what I see at home? So let's go to the the raw data to see what that looks like. And we'll get there in just a second. But what sort of seizure types are people having across the lifespan? And this graph helps you understand what are the challenges of trying to get this type of data. So the blue line is the number of people that we had at different ages. So we had a lot of people that were younger and not so many people that were older. And so trying to compare, I got to go back. This versus this gets a little challenging. So here, this is the count of seizures versus the patients, number of patients. So a lot of people are having a lot of different types of seizures. And this is what the seizure types are that are all coded down here at the bottom. If you look at that a little bit differently, this is the number of simultaneous seizures here on the bottom versus the number of patients. So there's basically, when you look here, it's like, oh, there's some separation here between the two at the younger ages, but as you get older, there's less of a separation. So the numbers of patients are small, but it looks like as you get older, epilepsy continues to be a feature of what's going on with FOXG1. Now, what are the features of those seizures? Now, this is, again, one of Ellie's favorite, a heat map. So basically, hot colors mean a lot of people are having seizures of a certain type. And so a lot of people are having tonic seizures. A lot of people are having seizures where their lips turn blue. And a lot of people are having seizures with a lot of staring. So I think this is important because this is what a lot of different things in FOXG1 can look like. And so I think it's always important to say, as we'll get to, was that really a seizure? Now, you can't really read this because in terms of the words, but basically it's what the picture looks like. So each one of these lines is a patient. And so when the line starts, that's when we started seeing them, but we saw them throughout their whole life. And so this is our oldest patient, 35, and we'll go back to that initial diagram, but basically she quits having seizures a little bit before the last time that we saw her during the study. So was she really seizure-free? Because that isn't a long time to be seizure-free. So that's her. And then this young man is important to know. It's like, okay, there's nothing on his line up until when we saw him when he was almost 10. He hadn't developed seizures yet. And here's another one who the last time we saw him was here, and they had seizures when they were quite young, and then they went away. So, if you look at everybody across this area in here, almost everybody's having epilepsy, but not everybody. So there's a lot of variability in what epilepsy looks like in FOXG1 syndrome. And so I think that's important to hold that thought as we think about where we want to go with clinical trials. And the answer is that to the question, is that our primary outcome measure? Well, it can't be if everybody's so different. So we have to think about things bigger than that. So what does seizure frequency look like in FOXG1? And so these are different numbers about average frequency versus maximum frequency. And so this goes to absent, monthly. Now look at the absent. There is a significant bit of the pie here, and some people are having them less than monthly. And this is half of your pie. But then you have a lot of people that are having them more frequently as well. So there, again, there's a big variability in what we see in terms of average frequency. And this is just maximum frequency. And basically the bottom line is there's a lot of people that are having daily and multiple times daily seizures, which is a challenge. Seizure duration, again, some are brief in terms of seconds, but then a lot of people are having them longer in terms of minutes, and a good chunk of people are having 5 to 10 minute seizures here. And this is the maximum duration on this side. And again, it just shows that there's a lot of variability. So you saw this diagram before. I like it because, and it kind of goes to what we just heard from Dr. Pong, is about when I look at this plot of the different medicines that people are on, what does it look like to you? It looks like spaghetti and fettuccine to me. And it's just all a big mishmash of people on different drugs for unclear periods of time and switching to all sorts of things that doesn't really make much sense. Basically, for FOXG1, basically almost all of the medicines have been tried. Having said that, there are only rare patients that are on cenobamate, and certainly wouldn't have been surveyed in the last study because it really has just become not only available, but more people are starting to use it in FOXG1. It's like a lot of drugs, is when you get to these newer generation drugs and you're trying to put a patient on them, is there's paperwork. And you have to file these things called prior authorizations, and somebody else has to approve it. You know this. There are a lot of what I think are confounds in epilepsy treatment in FOXG1. I do wonder a lot about this. When I've looked through the 10 folks that we follow in our Rett clinic with FOXG1, I think that there's often a tendency to perhaps overtreat things that may be movement disorders as seizures. And I think that trying to understand that better gets to be a challenge. Your individual has both a movement disorder and FOXG1. And so I think because it might be easier for an epileptologist to throw more seizure meds at your individual, that the movements might be treated when it may not be the right thing to be treating. Measuring duration and number of seizures is really a challenge. When people are in clinical trials, the gold standard is you go home with a seizure diary. Who here's filled out a seizure diary ever? Was it fun? Go on, tell me the truth. Did you fill it out in the parking lot before you went in for the visit? And you were supposed to fill it out every day over the month? Go on. We know that people fill it out in the parking lot before they come in for their clinical trial visit. So they're meant to be the gold standard, but it's really hard for you to sit down and fill out every day what happened. I think that there is a balance of side effects and seizure management. We talked about this at the last conference. You know, the goal is keep trying stuff, but we may not get seizure freedom, but we always need to be cognizant of the fact you put somebody on a medicine, you need to have a plan to take them off the medicine. And so I think it's important to be careful and keep quality of life in mind. So now this is what you wanted to hear about, how I've solved the sleep problem. No joke, disrupted sleep is common in FOXG1. So in the nice big paper that came out from Nadia Bahi-Bousson's group in 2018, 65% were reported to have issues with sleep. And then the data aggregation study, it suggested 51% of people had challenges with sleep. Again, the newer data that Ellie showed is it's probably a lot more than that, probably close to 70%. Is that what you showed? So what we know from just asking the basic question, what is it about sleep? Just asking the basic question, is it trouble falling asleep or trouble staying asleep? Just beyond those two questions, not much more has been explored, but basically both are the issue. Difficulty initiating, but with then multiple awakenings at night, often inconsolable. But how the specifics of this are not quantified yet. Standardized assessments, I'm really looking forward to the data with the child's sleep health questionnaire to kind of quantify that a little bit more, but it's so far been limited to small samples. And of course, nobody's done an intervention to see what works or not. Here are some sleep management suggestions. One of the challenges is that when you look across all neurodevelopmental disorders, they're small case studies, they're not controlled, and not a lot of different things have been tried. In general, just for looking at the broader literature across everybody who, outside of neurodevelopmental disorders, because it's a big business actually, sleep medications, the high quality data in general is really limited. The efficacy data in adults, even outside of neurodevelopmental disorders, only exists for the so-called Z drugs like Ambien and orexin antagonists. The other drugs that are more commonly prescribed, such as risperidone, trazodone, et cetera, they're frequently used, and the data for some is just either not there or it's horrible, but that's often what gets used. Having said that, trazodone is one of the most commonly prescribed drugs with really limited data to say that it's helpful. There is data, again, in very small studies that suggests that the Z drugs may be contraindicated in neurodevelopmental disorders. The other thing, is anybody on a Z drug? Oh, it'd be like Ambien or... We can talk about your drugs. One of the suggestions I have is when you think about, I want to manage sleep here, let's think about separating initiation versus maintenance, because the two are often treated a little bit differently. So it's important to take care of a lot of the other things that are going to keep you awake, and that's constipation, reflux, tone, urinary retention. If you're uncomfortable, you're not going to go to sleep, and you're not going to stay asleep. So initiation, this is the one place where you can do things around the house. Set the mood, set up regular times, so behavioral interventions. Now, having said that, I think that they're good to try, but with our folks, behavioral interventions only go so far. Then, to try to get you to go to sleep, melatonin is helpful. Now, one of the issues with melatonin is it's treated like a vitamin, and so even though it says 5 milligrams on the bottle, it's not following the FDA goalposts of being within 80 to 110% of that 5 milligrams. And so sometimes you get some melatonin, sometimes you get a lot of melatonin. So if it's not working for you, try a different brand. And there's a number of different doses that you can try, even up to 10 milligrams. You can even try the extended release preparations. Those you have to get with a prescription. For maintenance, try one thing. If it doesn't work, come off of it, try the next thing. I start, even though there's not good data with it, I start with something mild like gabapentin, then I'll try triclonidine. Trazodone does work in a number of people, even though I just really trashed it 2 seconds ago. It also may have some anti-seizure properties as well. And then they're hard to get a hold of because even though the best data exists for the orexin antagonists, none of the prescribers want to pay for them. And again, there's a lot of paperwork to go through for that. So in terms of how we want to go forward with measuring how well different things work, let's start with a quick statement of the problem as how I see it. We've got multiple symptoms, but most importantly, and this is how the FDA sees it, is what are the patient priorities? That's why it's so important that you guys participated in what Ellie was doing, because the FDA, it's like, okay, that's great, but what do the families think? And then we want to get to new, approved, cost-effective therapies. How do we get there? Is it really that hard? There's a lot of different clinical challenges, research challenges, infrastructure challenges, regulatory challenges, and institutional challenges. We're not going to talk about all of those today, but I wanted to talk about where I think we're at. This is what it feels like with FOXG1. You've got a lot of different symptoms, and they're just kind of all over the place with varying degrees in severity. And this is my graphic of, wouldn't it be nice if we could align and measure each of these so that we could then determine meaningful therapies to people and families. So, what do you want? We asked that question in a special way when we did the natural history study. Again, this is those 62 families. We asked the question this way, not in terms of what symptoms are you having, what are your top 3? We gave people a list, and then we also had, a fill in the blank. A lot of people ignored the list and just filled in the blank, but it turned out they were the same as what we had in the list. But FOXG1 is, of course, here on this far column for you to see. But the thing that rose to the top was lack of effective communication. Seizures was right behind that, and it may not have been statistically different, but doing the statistics for this type of question was really hard to do. And then sleep was down here. Now, look at all of these things that are on the list, okay? There's a lot of things that are on this list. If you are on the list, you ranked it as a top 3. So all of these things are important to everybody, and so we can't ignore them. So how have we approached this in general? Not in general. We're approaching it for a certain type of a developmental epileptic encephalopathy called CDKL5 disorder. We got a grant from the NIH. This started in February of 2021 to try to develop outcome measures for clinical trial readiness for CDKL5. So our home is here in Colorado, but we've got partners all over the world that we've been working with to move this whole study forward. And basically, everything that we've been doing has been driven by our patient advisory groups. That's what PAG stands for. So one of the challenges is it's the same challenge that you have. Currently available clinical outcome measures are not validated for CDKL5 disorder or for any other developmental and epileptic encephalopathy. And the challenge is you can't use something that's off the shelf because it may not be sensitive enough to measure those changes and challenges that are meaningful to you. And then the other issue is there's no biomarkers, and basically CDKL5, same position that you guys are in, is that gene therapy and other disease-modifying trials are planned for the very near future. So what have our methods been? So we wanted to refine, psychometrically test, and create training materials for new measures for CDKL5 disorder. Now the formatting, I just see has really jumped a bit, but here. So basically there's a clinician measurement, and then there's parent measurements. One's a clinical severity assessment, then there's a measure of communication, quality of life, sleep, social determinants of health, and then you're asked to do gross and fine motor video assessments that are done at home. Just to go back, I asked the families, how hard is this to do? And it's to do it once, it's okay. But to do it several times, it's a challenge. But it's doing it several times is required to look at a number of different things. One is you want to measure that works. If I measure and I give you a number of a 35 today, if you come back in 2 weeks, am I still going to get a 35? Or am I going to get something that's really different? In 2 weeks, you shouldn't have changed very much. So that's one of the aspects of when we test these measures, that we make sure that they're actually working. So the other thing is we want to do is we want to correlate all of these with EEG and evoked potentials as our biomarker. And what we've done so far is that with all of these in 150 subjects is that all of these look good, except for one of the thing that was most important to you, which was communication. So there was an off-the-shelf measure that we thought was going to work called the CSBS. It had what we call a floor effect. And that means is that everybody was shifted to the end of the curve. So we couldn't measure, I'm getting the sign to wrap up. It meant that there might be change in you with a clinical trial, but the measure wasn't good enough to measure it. So, the formatting went off again. But the bottom line is that we're now in a longitudinal study to look to see how well these things work. This is just basically showing that our outcome measures perform really well compared to our biomarkers. And one of the issues with the FDA is they're like, okay, great, you've measured a lot of different things. But the FDA are quite simple. They want you to measure just one thing. Just tell me the one thing that's meaningful to families. So what we've found is that with a lot of math, we can turn and put all of our measures into one overall severity score that tracks really well with our biomarker and with quality of life. So it is possible to measure all of these things that are important to you, to turn it into a number that we hope that the FDA thinks is going to be reasonable to use as an outcome measure in a clinical trial. So wrapping it up, epilepsy is a common feature in FOXG1 with variable seizure types, frequencies, age of onset and offset, and seizure outcomes. There are no particular medications that work well for seizures in FOXG1. Understanding the impact of epilepsy on our people and families is less understood. Sleep is a challenge for our people and families. The specifics, though, of the impact, the natural history, features, and treatment definitely need a lot more study. And epilepsy and sleep can be unified into outcomes that address the breadth of people and family priorities. So these are my folks that I work with. Couldn't do anything without them. And questions?